Hi, my name's Savina and welcome back to the Medapply YouTube channel. In today's video, we have Dr. Juhee speak with us on her journey through medicine, the highs, the lows, and everything in between of being a doctor. Dr. Juhee shares some really great content on her Instagram page, especially helpful content relating to medical education. So be sure to give her a follow. We've included all the links in the description below. Please enjoy Dr. Juhee's talk.
I'll be talking about my personal story, going through the common things you should be aware about if you're not already, if you're thinking about a career in medicine. So life as a doctor, high, lows, and everything in between. So just a little bit about me. I am a GP ST1 doing an academic ITP. ITP is basically an integrated post. So when you think about specialty training, this is way after medical school. You have lots and lots of options. So you can just do normal training, and you can also get integrated posts. So you have, if you're interested in, for example, working with children, if you're interested in working with the King's Fund or public health or academics, you can get posts like that as well. So it's always good to read around what's out there. So I'm doing that. This is my first year of training. My special interests are minor surgery, public health, med ed, health inequalities. I was the surgical clinical teaching fellow at Imperial last year because I was thinking about career in surgery, so I'll cover a little bit about that today. I'm also associate clinical teacher at Imperial College, and I'm also a medical school applicant interview. I've done them last year, and I'm probably going to be doing them this year for Imperial College. Also the chair of the London Trainee Network, so that's all medical, surgical, general GP trainees in London. We've got a network, a committee that reports to sort of the director of education across all the trusts. So we're a little trainee-based and trainee-formed committee. I'm also part of the Royal Society of Medicine National Trainee Council Committee. We hold educational events throughout the year, which obviously has been severely impacted this year. And I'm also a clinical skills tutor and OSCE examiner at St George's, where I studied. And I've recently set up an organisation focusing on health inequalities called BAME Health Matters. So I'm also the chair of that. So just want to ask you guys, how long do you think it takes to become a doctor? There's a range, which is good. It depends what we're talking about as a doctor. So really good. So I just wanted to make you guys think about, yes, you go to medical school, you do 5 years of training, usually if it's undergrad. Postgrad can sometimes be 4, or you can do 5, and then you can do an additional intercalated BSc, which is 6. And after that, you are officially a doctor, but depending on what you want to do later, what you want to specialise in, there's many more years of training after. So I'm going to talk about my journey. First of all, I was born in Scotland, in Glasgow. I lived there for 12 years, and then I moved to London, North London, went to school. Then I went to a sixth form in City of London, which was a really good experience. And then I applied for medical school. I applied for all London unis because I wanted to stay in London. I didn't want to go. I eventually ended up choosing St George's because mainly when I went to the open day, I had zero expectations of what I thought St George's would be like. I hadn't even heard of the university, and I hadn't even thought about it as being one of my top. I always wanted to go to King's, and I went to King's and I was slightly, for myself, a bit underwhelmed, just maybe because I had really high expectations. Obviously, all great universities have different strengths, but I ended up falling in love with St George's, so I spent my 5 years there. And I also did a degree at Imperial College for my BSc. So I graduated from St George's, and then I also graduated from Imperial College. I did cardiovascular sciences. So yes, I was thinking about doing medicine instead of GP or even surgery during medical school. So it just shows how you can think about going through so many careers when even before you've started working. And just a little bit about life as a medical student for me in my university. So year 1s and 2s are mainly lectures, seminar based. We were quite unique in the way we have an integrated degree. So we have both case-based learning and small group teaching for communication and clinical skills. The really good thing is that we have a lot of early years clinical experience. So small weeks in primary and secondary care. So you can be in GP, geriatrics, radiology, medicine, surgery, pretty much as early as your first and second year. Not a lot of it is expected from you. So I know that might be like, oh my gosh, that's a lot, but it's very, very small, and it's just to get you used to what it actually will be like when you are a doctor very early on, but the expectations are very low. And you also get to do something from your side, which is called a student selected component. I then chose to do my BSc after second year. So the good thing about George's is you can do it whenever you want, after second year, after third year, or after fourth year. And if you do it after your fourth year of medicine, you can do a master's. In other places, for example, at Imperial, they all do it after their third year, so it's kind of their official fourth year. But that's completely, again, up to you guys when you think about applying to universities. And some places, you know, they don't do it at all, and then you have to apply externally, which is, we had internal and external options, which was really good. So BSc is slightly different. You don't have to do it, and I know with the FPass changes this year, it won't count as much, but it does count in the future when you think about specialty training. So if you're interested in something, it's definitely something to think about. Mainly it's self-teaching, and you do a lot of essays, coursework, so it's quite different to medicine in itself. So it's a good experience. Year 3 in St George's is called the transition year, so it's much longer in terms of clinical placements, and you have 3 core placements: medicine, surgery, and GP, and you also still have a little bit of student-to-student contact in problem-based learning, and again, you get to do a student-selected component, which is basically a project or an experience that you're interested in, and you can organise that yourself, or you do get support from the university. Year 4 of medicine, the penultimate year, is mainly specialty based. This might be 5th year in places where the BSc is compulsory. This goes into more of the subspecialties in surgery and medicine. In my university, with palliative care, neurology, psychiatry, obstetric and gynecology, and pediatrics are very common as well. And in the final year, I got to do a bit of emergency medicine, critical care and anaesthetics, public health, medicine, surgery, and GP assistantship, which just means that they expect a little bit more from you, and they start treating you a little bit more of a junior doctor in an SSC. Obviously, given coronavirus, things are a lot different for the final years, and even probably the younger years, but I'm sure the medical students later on will cover that. Other things to do as a medical student. So remember, you're not only there learning medicine, it's really, really important that you try new things, experience new things. So I joined various committees, global health, Punjabi society, did a lot of dancing. I also got the opportunity to be a peer skills tutor, so St George's is quite unique in that I know more universities are doing that and adopting that sort of structure, but it is been there many years for St George's, and you get paid eventually. So it's a good thing to think about. So I did that applied after second year, did an interview, and then you basically teach younger year groups clinical skills, comm skills. Everything's provided for. I also ran a lot of OSCEs, revision sessions, organised conferences, TED Talks. There's something called Teddy Bear Hospital, which is in a lot of places across the country, where you go to schools and educate children about medicine, and any kind of alleviate the concerns about going to the doctors. And you can be part of the student union as well. Just to show you, there is much more than just going to lectures and learning medicine. It's really, really important you do make the most of whatever degree you do at the end, but also especially medicine, to keep you sane, because it's a long, long course. So I did a lot of dancing, and I did a lot of plays, because that's kind of stuff I enjoyed, got involved in Charity Week, organised events. So just a reminder that when you are going to your interviews as well, it's nice to talk about other things apart from just the course, and having a good idea of what they offer, what is unique to that university. So more onto about medicine and being a doctor generally. So the NHS training pathway overall, start as undergraduate, do the foundation program after you've graduated. So that's 2 years, F1, F2, and then you go on to specialty training. But now it's more and more flexible. So you can do a BSc, as I mentioned, you can do a master's after your 4th year in undergraduate level, and then you can obviously add that onto your postgraduate level. Even after foundation year, after you've got your license ideally in F1, there are lots of opportunities after your F2. So you can do an F3, which is what I did, and I'll talk about that. You can become an academic fellow, clinical fellow. So academic is more research, or it's more university based, and the clinical fellows are more trust associated. So you do a little bit of working in the hospital, the GP, whatever you choose to do your clinical ship in. And then you can also locum. So locum just refers to taking on shifts in different hospitals and different institutions and helping them out as ad hoc. So you don't actually have an official contract. You'll pick and select your shifts and sort of flexibly work. You do sometimes get paid a bit more, so you have more time to yourself as well, but it's not as stable in a way. Also can do PhDs, and often staying in London during your specialty training programs, it is now sort of more and more expected that you do a postgraduate degree, MSc or PhD. So it's something to think about if you want to stay in London and you want to do a competitive specialty. And out of program years, so it doesn't all have to be medicine related. If you're interested in humanitarian medicine or doing something completely different or traveling, you can take out of year programs years out. So it's just important to know that it's just not a single pathway. It goes up and down, in and out, and it's all in your hands. But it is very self-directed. You need to do the research. You need to talk to people. It's very in your hands. This looks like a very busy slide, and I apologize for that, but it just shows you the different ways of getting into medical school, the different medical school things that we talked about. You can do an integrated degree, or you can do an access course before you start your actual medicine degree. And then afterwards, as we talked about, you can do the foundation program. The academic foundation program just means that one of your blocks will have dedicated research time, so you don't usually do any clinical work, service provision. You might do clinical research, that's separate, but that block of 4 months is just pure research. Often there is an interview for this, and they do expect you to have a little bit of interest in research, ideally a publication during medical school, but things are changing. It depends how you come across in your interviews, but there's a lot of support information out there now, more and more with social media especially. F year is very, very common. A lot of people do an F year. I think about probably a near 80% of people who I did F2 with went on to do an F3 year, and the rest of them went straight on, but it was quite a large proportion of us. So I chose to do surgical clinical teaching fellowship, where I worked with medical students, and I taught Imperial College medical students at St Mary's Hospital in London. It was clinical based, so I was in the trust, so when they're on their surgical placements, I basically sorted out their ad hoc teaching and what kind of was there for pastoral care, any support. It's quite a nice experience, especially if after your 2 years of working you are feeling a little bit overwhelmed, and that's very, very common. It's quite a nice break. The other options, as I said, is you can do something completely unrelated to medicine, go traveling, do some locum shifts to keep you afloat money-wise. And yeah, the possibilities are quite endless. And then the main things to know is you can specialize in medicine. It's IMT now. There are some core trainees around, but it means the same thing. So you've got the medical pathway, you've got the surgical pathway, you've got the acute core STEM pathway, intensive care, emergency medicine, anesthetics. You don't need to know the ins and outs. This is just a brief overview, and there are a couple of more run-through training programs where you don't have to reapply. In the medicine and surgery, if you're doing the core first or the IMT first, you have to ST3 level have to reapply, meaning go through interviews again and do exams. So the exams and the lifelong learning never ever ends, and you really should be aware about that before you think about a career in medicine. So coming on to life as a doctor, what do you think a junior doctor does? Just to reinforce, junior doctor is not only F1, F2, so the 2 years, it goes up to register all those 8 years, the ST1, they're all called junior doctors until you've got your qualification into whatever specialty. But yes, the level of responsibility and jobs and the roles changes. So let's think about a little bit more closer to med school. So F1, F2, and the earlier on training part. Yeah, great. So placements, tests, cannulation, shadow senior doctors, yes, help out any way you can. Yes, that often does happen. Training, a lot of training. Ward round is going to be something you will all experience from medical school, and it becomes sort of your bread and butter when you start working. Clinical research, that is very important. If you're interested in research, it's very much on you to take that initiative. Writing notes, history taking, ABGs, yeah, so all of you don't know what ABG is, all just kind of investigations, taking bloods from patients, etc., like that, organizing scans, creating schedules, patient exposure, diagnosing. Yeah, diagnosing starts from day one, and you're not often going to be having all the responsibility as an F1, F2 to do that, but it's very good to learn and pick that up, because you might be able to diagnose something and then discuss that with your senior doctor, and it really reinforces your learning. So starting doing that from day one is really important, even in medical school. Great. Yeah, you guys have got pretty much the right idea. So let's go back. So a normal day, which means you're not on call, which I'll come to. Early mornings, you'll get used to that. Medical school, you might not still have early mornings because you might miss lectures, completely normal. But yeah, you'll get used to the working life, prepping list of patients. Depending on what team you're on, you'll have a list of patients that you look after, patient notes, taking handovers. So remember, we are a 24/7 service provision. So there'll always be a doctor overnight. They might hand over stuff, something's happened with X, Y, and then you need to write that down or make sure it's documented and that's updated to let the senior doctor know. Having a ward round, which literally means going around your inpatients with your team, usually is senior led. Making a job list. So job list, as you already guys mentioned, investigations, bloods, inserting cannulas, inserting catheters. Again, you learn all this through medical school. Prescribing medications, often quite scary at first, but again, it is all supported, and you do start all of this in medical school, learning about it, not prescribing itself. Referring to specialties, again, this is more of a non-clinical skill, but again, you pick this up as through observation in medical school, and again, just learning when you're shadowing on the wards. Examining unwell patients, that will often be a responsibility from day one. Writing discharge letters, slightly more admin side of things, which does take up most of your time. And teaching medical students, so once you've graduated, you will always be teaching. You may not want to teach, that's okay, but you will sometimes have to teach a little bit. Have lunch, very important. A lot of people skip lunch, don't do that. Make sure you eat, have emergency food on you. Jobs, you carry on jobs in the afternoon. Things may change during the day, so acting on that, you might get investigations back. Again, going to see those patients, and always remember you can ask seniors for help. From day one, do not ever think you are by yourself. Even if you are alone on the ward, there is someone on, you can call, you can text. WhatsApp is amazing. So, that is something to remember. You're working in a team in the NHS. So even if you're by yourself, there will be someone to ask for help. And then you hand over. It's the same process. You hand over to the night team or the evening team, tell them what's happened during the day, anything they need to do. So if there's any jobs that are still pending, that's okay. It's time for you to go home. You hand that over. So on call just means times that are not the normal working hours. So early mornings, late evenings, night shifts. You may have a ward round to do, you may not, depends on how it works, and it varies from hospital to hospital, department to department. You generally may cover more wards, so the service goes a little bit more quieter in terms of less people around. So you might be covering more medical wards rather than just your one team. So there's something to be aware about. You might be part of what we call the MET cardiac arrest team. That means if anyone's really, really unwell and they need CPR, you might be part of that team. You get a bleep that you carry around, and you will go and see unwell patients immediately. How many junior doctors are usually on call? Again, this varies completely. It usually is one medical doctor, one surgical doctor. You may be lucky and have two, but that doesn't happen usually. But again, it varies from hospital to hospital. But before you start, especially F1, you'll get time to shadow, you'll get time to get used to what the on-call is like. But there is always someone to call. So there will be a senior doctor, might be what we call the F2 or the SHO, which is senior house officer. So that's someone earlier on in the training that higher than you. There will be a registrar around. So there's one person at each level around. They just might be doing different things. So you might be covering the wards. They might be clerking new patients in A&E for medicine and surgery, but they are there to call. So even though you're sort of just looking after them, if there is something you need help with, it is expected that you will contact them, or they can come and see the patients if you're really worried. Yeah, so as I said, you will mainly examine unwell patients when you're on call. You're not expected to go through everything again, do kind of routine jobs. That's not expected on call. It's just to make sure that people are alive and well and they're not deteriorating. And you might have new patients to clerk, but that's past F1 when you're a little bit higher. Sometimes in F1 they expect you to do that, but don't worry, you usually will get a little bit of support. It's a lot about prioritization and time management, which you learn through medical school, but mainly you learn on the job. I have to say, most of the stuff I've picked up is just being through my job rather than medical school being exceptionally pregnant. But for a lot of people, it depends. Know who's available. That's the main thing. In each hospital, it's slightly different team members. There's also a lot of nurses that can help. So they're slightly higher trained nurses. I don't mean the ward nurses. They obviously look after your patients, but you have kind of outreach critical care nurses who might come and see patients if you're really stuck and you can't, get hold of your seniors. And then again, same thing, handover and you go home. And you do get time off in between. You're not expected to work continuously, although sometimes the schedules can be busy. So the main thing, as we've briefly talked about, life as a junior doctor, you'll be rotating often. There's lots of new teams, so adapting to different ways of working is a key skill that you need to pick up. And again, something to mention in your interview, that you're good at, teamwork and changing to the needs of, the teams, and, adapting the way you work with different team members. And yeah, you may be in different locations. You often choose which area you select in when you apply for your F1 or F2, for example, after medical school. So they'll put you in a localized area. So London is divided into currently 3, may change to 2, but north, south, northwest, northeast, south. But it can be quite big. So you will rotate between hospitals in itself. But often as you go up the chain, as they say, you do have a little bit more control. But again, even then, even if you're in London, sometimes you can get a job in East London and then you're in West London again, depending on what career you do and what, their borders are. But, that's something you can research about as you go along. Yeah, new experiences. So the other thing to think about, and also again to mention in interviews, is talking about the unique experiences as a doctor. So death, okay, my first death in my F1 and verifying death. Yeah, I heard about it, read about it, saw one at medical school, but it's just completely different when the sole responsibility is on you to go in and assess that patient. So it's something to talk about, and it's not something to shy away from, but it is difficult and it is a new experience. But you do have support, communication, asking for help, talking to your teammates is really, really important, and knowing the patients well will help you with that. Sometimes you have to deal with relatives. Often we say that more senior doctors should talk to relatives, but unfortunately you may be in that situation when no one else is there and you have to talk to them. But always have a nurse or another team member around with you. Always ask for help, and it is very much on you. Some people will offer to help because they're brilliant, but some people you just have to be like, this is a bit of a difficult situation, please can you come with me and can we talk to this relative together? And often the matron and the nurse will do that. And also stressful environments, working with limited resources. Got another question, how do you prioritize a job list? What sort of jobs would you do first and what? So leave for later. So often if someone's unwell, that's always going to be your number one job, is making sure they're stable. You will learn again about this in medical school. It's called ABCDE. So looking at airway, breathing, circulation. So these are things that essentially kill you first. So stabilizing that. So that's, again, all of this technical stuff you learn. But it is stuff to do with unwell patients. You need to get an urgent blood test on someone who's got newly short of breath. And they're not looking well, they're fainted, or they've not got a pulse and you've put out a cardiac arrest call, stuff like that. Dealing with the unwell patients really comes first, and more routine jobs come later. Sometimes you might have to do a more routine job earlier, like discharge letter, even though it's not really the most important thing, but discharging patients is also important to make sure you have beds available for new patients coming in. Especially during COVID, we're really, really pushing on discharging patients who can go home and stay safe at home. So it's the way you sort of describe that. And obviously if someone else is unwell but they're stable, you can maybe do that first and come back to it. But again, all of this you learn through medical school. It's just kind of like coming through your time management. You've got a deadline tomorrow. That's obviously more important to do, finish that coursework before you revise for an exam that's a couple of weeks away, something like that. And just going through the thought processes. Accepting you are not perfect, that is really, really important. And my friend has just started her F1 and she's going through that, and I'm kind of guiding her through it. The main thing is to accept is that you are not perfect. You will make mistakes. You are human. You will learn from mistakes, own up to mistakes, talk about mistakes. People might be horrible to you as well. Don't take it, but also be a bit considerate. Maybe they're having a bad day. Maybe they're not also perfect as well. It's just a little bit of humility goes a very long way. Eager to learn, as I said, loads of exams throughout your training. Always be eager to learn, be prepared. always think about what rotation you're going to be on. This is even in medical school. If I'm going to be in, ENT, which I'm just on at the moment, which is ear, nose and throat surgery, I'll need a head torch. I'll need, I don't actually need to carry an otoscope, which looks in the ear, but knowing that I know where the otoscope is to look in someone's ear when I need to, having a pen and a notebook or a phone is the most important thing, and a stethoscope. But again, as I said, learning about your specialty and what equipment you need, and you can ask anyone who's on it. Everyone is so friendly in medicine that you generally will learn a lot just by asking people. Technology, so we're lucky in that we've got so many apps out there, even for medical school and for medicine itself, drugs, guidance for what antibiotics to prescribe when you're a doctor. All of that is all out there. So being very clever and keeping up to date with technology is important. And also just thinking past, yes, you might have XYZ rotations because you didn't have much choice as you what you wanted to do. But if you're having a more medical year as a doctor and you want a little bit of taste in surgery because you're interested, you can organize that and you get leave for that. So making sure that you make time and being organized is super important. But taster weeks are always present, so it doesn't matter if you've not had any experience in your rotations. When you go to apply specialty training, you can get a little bit of experience through these taster weeks. Seeking new opportunities and projects, so that's, again, you might be lucky that you have a senior around you who's like, oh, do you want to get involved in this? But often you might have to be like, do you have a project? So you seek new opportunities and projects from that mainly by talking to seniors. And the main thing is not to take on too much, so take time for yourself, and that is the most important thing. Okay, burnout is a big thing, resilience, all these kind of buzzwords, but it's just mainly just taking out time for yourself and not overwhelming yourself. Okay, the last few points to end on. So the other things, as I've briefly mentioned before, teaching, leadership management, quality improvement audits, research, presentations. These are the other things you will be expected to do outside of your clinical day-to-day jobs. So that's mainly that, and exams depending on what specialties you do, presentations. And just briefly, this just gives you an idea. If you're thinking of GP or surgery, you obviously will not be thinking about that right now. You do have to do exams, interviews, score yourself, show, for example, if you're doing surgery, you might have to do exam before you apply for surgery, do lots of surgical courses, which is what I did when I was thinking of applying to surgery. So ATLS, which is life support and trauma, basic surgical skills. And you can do some of these courses in medical school, thinking about operating and observing in surgeries, thinking about making your elective in medical school, or F3 more surgical based, doing additional degrees, prizes as soon as you enter medical school, you can enter them. And if it's not too much hassle, not doing much, then you can apply. It's not the end of the world if you don't, but these are just extra points. Teaching experience, really important. You should enjoy teaching a little bit if you can, because that is expected in medicine. Training and teaching presentations. So these are kind of things, if you're thinking about surgery, you really need to be building your CV up. Even if it's after graduation, don't worry, you can still get a great CV. It's not all, day one of medical school, I need to do all of this. None of that. I didn't do much apart from other stuff to make myself happy. And then I did focus on it kind of post-graduation, and I'm doing pretty well, I'd say. But yeah, GP as well, there's a bit less focus on the portfolio, but you do have an interview, not this year, but usually have an interview and exam. Publications, leadership management. And then just the final thing to talk about, there is lots of pros and cons in medicine. You have a supportive system, make sure you have interests and hobbies, you reflect on your work when you leave work, and leave work if you can at work and not take it home, and think about your team, try and get to know your team. Because generally people are friendly, and if they're not, then you can just stay away from them, but generally you'll find someone who's friendly. And just think about the cons as well, especially in your interviews. Be aware that there is long unsociable hours earlier in the training. However, there are careers that are a little bit more nicer in terms of hours. Death is going to be a big part, unwell patients are going to be a big part of your life, studying, managing workload, moving around, personal stress. So as long as you're aware of these, you will always find a way to work around. It's just knowing what's out there is super important before you think about applying to medicine. And I think that is it. You can reach out to me via Instagram. I will reply. I'm also on Twitter and TikTok. I don't use TikTok that much, but Instagram, drop me a DM if you have any questions. I'm more than happy to help in any way. And obviously Medapply are obviously there for all your services. Thank you so much.